It's Dana here from the Future Proof PT podcast. Episode 11 is going to make you think differently about where our profession is headed. Alex and I have Cody Lee back with us, an early career PT who's been right in the trenches of changing direct access laws in Alabama. He's helping physical therapists also integrate AI into their everyday lives at work to improve the value of the care we provide to patients, upping our evidence-based games while thinking about the whole person as we provide and coordinate patient care. Look, we get real in this episode. We're going to tackle tough questions about direct access that keep coming back up in break rooms and online forums. Does having a DPT actually matter for autonomous practice? Why are some PTs actively fighting against expanding our scope or even working up to our full scope? And what can we learn from other providers about pushing our profession forward? Cody shares with us a fascinating story about how one patient's experience with vertigo turned into a powerful moment in front of a state legislator. But beyond the advocacy win, we go into the deeper stuff, like why some of us shy away from more clinical responsibility while others are ready to step up. Whether you're tired of waiting for physician referrals or you're nervous about taking on more clinical autonomy, this conversation will challenge how you think about your role as a PT. Plus, you're going to get practical insights into how grassroots advocacy actually works. Not just the theory, but the real nuts and bolts of creating change in our profession from someone who did it. We are also excited to share that Cody just opened up pre-orders for his new course, AI for PTs, and it's a 90-minute clinician-tested guide to using tools like ChatGPT, Claude, and Gemini to streamline documentation, synthesize research, and enhance clinical reasoning. If you're curious about how AI can save you time in the clinic and really want to learn from someone who's applied it firsthand successfully, you're going to love this episode. The full course that Cody's offering does launch on June 1st. Early access and early pricing is open now. There's links in the description, but if you just want to go to aiforpts.com, you can get 10 free high-impact AI prompts as a little gift from Cody. And with that, let's get right into the episode. Hey, everybody. Welcome back to episode 11 of the Future Proof PT podcast. We are here back with Cody Lee, a physical therapist, earlier career down in Alabama that we've had the fortune to meet and already recorded a first episode. If any of you have not listened to that, we've gotten great feedback. Maybe go back and listen to that first. But if you don't, this will be great anyway. I'm going to kick it over to Cody to give us just a quick high-level overview of what we covered on the first episode and talk a little bit then more about things like the work that he did at Alabama in the direct access debate and how they secured some of their successes in advocacy. So Cody, if you want to kind of kick us off and we'll go from there.
Yeah, thank y'all for having me back. Really enjoyed being on the first podcast. A lot of fun. Have had some good feedback from it as well. So I'm glad to be able to be back and hopefully continue to provide value to the listeners and just kind of talk through some of these other topics we've got on our mind today. But last time, some of what we briefly touched on was a little bit of kind of how my journey has begun as an early career PT, a little bit of my background, getting involved with some leadership aspects early on, getting involved with the Alabama APTA and what that's looked like and volunteering there. And we touched a little bit on the value-based care principles. I've learned a lot more from listening to the podcast here and how I've been able to implement some of those in daily practice and how that's already been impactful. And then we also, looked at using AI as kind of a clinical thinking partner and how I'm using that in the daily workflow and incorporating that as almost like a clinical decision support tool. And a couple other things we covered too were just professional growth, for early career PTs, what that's looked like for me, and then servant leadership as a whole and kind of my philosophy around that. So would greatly appreciate it if you haven't listened to it to go back and listen to it. Would love feedback on it. Reach out to me on LinkedIn or my email or whatever.
Terrific. So one of the topics we talked about was the direct access debate. Do you want to talk a little bit about how you made that case, Cody? Some things that, maybe stand out that you think would be helpful for others who are thinking about either taking this to the next step in their state or just want to hear about what advocacy looks like, because it can seem kind of like a black box if you've never done it.
Yeah, definitely. And I would agree. It is a black box until you kind of get to see it up close and personal and really get to understand it. And I didn't have a good understanding of it until getting more involved with this last year. So for Alabama, I think we originally had some form of restricted direct access originally passed in 2012 where we could essentially do evaluation and that was about it. And then you needed a plan of care and that sort of thing. So a lot of people have gone before me in this process to advance direct access in our state. And probably the biggest one would be Emmett Parker, who's just been a champion of our government affairs committee and our state and our physical therapy association and just really pushing that forward here. But getting to see it last year, we kind of learned about it later in the process of when it was going on. And I think I kind of touched on the communication difficulties sometimes we have with what is actually occurring within the association and your local chapters. But it really became more of just supporting from the side a little bit more. I wasn't as directly involved to be able to go to the committee hearings and get to see those things in person, but watching them online and from afar really opened my eyes to kind of how this works and then getting behind the scenes aspect of what our government affairs committee is working on, who they're talking to, all the opposition that's up against it. And, it was like everything happened all at once. It seemed like nothing happened and then everything happened. And then it was like, okay, now we have to push really hard for this. So I think there was a big grassroots movement, and that's really what helped last year was what we did locally was contact our House representatives. So we have 5 here locally, emailing them, getting friends, family, patients, getting them to tell their stories, why this mattered to them, why direct access would be helpful for them as patients and really our community and their the people they serve as well. So that was really huge. And then being able to get in touch with them personally. And what was neat to see for me is, I think having not had any experience with the government really much was, they're people like us, they're just local elected leaders and they responded to emails, they responded to our arguments and questions. And so that was really cool just to see like, okay, if I actually engage here, then they'll engage back with me, don't just sit on the sideline. So I think that was really helpful. And we actually had one come into the clinic locally, credit to him because he wanted to see both sides and understand and educate himself as best he could to make a good decision on the bill and kind of moving forward. And so what was great was one of our patients was actually in his district and she was there and she had a story where essentially she had suffered from not having direct access. So for her in particular, she's had kind of chronic recurrent vertigo issues. And so she knew what was going on, but it was going to take her some time to get in to see her primary care provider who she needed to see to get a referral to come to PT. In the meantime of that, she actually fell. She broke her wrist, so she had more issues there. And so what was really huge was that patient getting to tell that story directly to that legislator. And that's really one of the big things that I think makes the difference is those patient stories and getting to see that and getting those people in front of them.
I think one important thing to discuss here is how do we go through the attention points on the provider side. So I've noted that direct access tends to divide physical therapists even in the trenches, where there's some therapists that don't feel like they're ready or they don't want to take on the extra risk and extra responsibility, right? So they're just very comfortable with a low risk provider model where they just get referral base and then the risk is being outsourced to physicians that refer to physical therapy. So how do we both stratify that risk, but also how do we identify clinicians that are prepared to take on that extra risk of direct access versus that are not? And the reference point being in United Kingdom, you have advanced practice therapists that go through extra licensure and then they can provide direct access care, or you can just be the traditional. So what do you think?
Yeah, I mean, I think with our entry level education at this point and being a doctoral, level trained clinician, I should be able to, when I come out, be able to identify red flags, identify things that aren't appropriate for PT, and then get that patient to the correct provider they need. I'm trained in my profession. I feel like in our education, we're trained to the highest level of our colleagues. So although I'm practicing in Alabama where we just had direct access passed, I was trained to the level of if I would have been in a direct access state. So I should be able to essentially come out of school, recognize these things that are not appropriate for PT, that are appropriate, and then coordinate appropriately in my, perspective. But there is definitely that tension and a funny or not funny, really more infuriating story from the direct access push was we actually had a clinician locally tell a health committee chair, who's one of our local reps, that we didn't need direct access as PTs. So own PT saying that about your own professions. So that was really infuriating to hear. And I think that was one thing that really lit a fire under me, as well as some of the opposition's arguments to really say, like, okay, if I believe all these things about my profession, about my ability, about my colleagues' ability, but I'm only on the sideline and I'm not doing anything about it, then I can't get mad if we don't have any progress, you know. And so these other folks who may have different arguments or different perspectives that I would say is incorrect, if they're going to tell their story, then they're going to say it from their side, then we need to be prepared to do it from ours as well. And I think it's on us as clinicians and professions. Like, if we want to see our profession move forward, then we have to just step up. You know, we have to be better. We have to continue to grow. You have to be willing to take the risk. Just step forward if we want anything better for our profession.
And there is that simple model of risk reward, right? So if we as a profession are comfortable with a higher level of risk, then we have potential of extracting higher level of reward. If we continue to maintain this low risk model, traditional model that one of your colleagues was having, that they don't want to partake in it, then that is the epitome of why we're struggling as a profession. That is how we fall into the lower reimbursement model. That is how we just continue to get sequestrated into these physician extender model instead of a primary care autonomous practitioner model.
Pose a question to you guys. Now, we're all doctorally prepared. I went back after 20 years to go from master's to doctorate for this exact reason, that I didn't want there to be ever a question that I was lesser because I didn't have the doctorate, whether it was clinical or non-clinical. And I know a lot of the outpatient clinics, at least around here, won't even consider you for a job in an outpatient clinic if you don't have a doctorate. So should direct access only apply if you're doctorally prepared, or should that be something sort of in parallel to what we have in the UK? Or should we allow it to be therapist by therapist, depending on what you feel your scope of practice is?
It is a wonderful question. I think it's a pertinent question to ask on a global scale. Does the DPT actually guarantee safety profile where we can take on the patient specific risk? I would probably venture on there has to be maybe a little bit more, or a certification or a form of a classification for this advanced practice physio, maybe even on a core competence, maybe on a fact that you can identify the red flags. But I think the DPT alone, it still creates a very large spectrum of clinical efficacy and clinical competence. And Cody, you probably can venture on this a little bit, but there are definitely clinicians that practice on the top of the license and they don't have a DPT. They have, like, it's someone with 20 years of experience, right? There are two ways to have a 20-year clinical experience. There's 21-year experiences and one 20-year experience. And so there's an abundance of clinicians that have 21-year experiences. They're just doing the same thing over and over again. And then there's clinicians with a bachelor's in physical therapy that really understand the process, they understand the model, and they have a higher level of competence than any DPT. But that extra certification, potentially, not to create extra barriers or extra tension points, but without it, how do you prove that we have done this safety profile? And I think that maybe direct access is not even the right way to classify it, because I think we need direct access regardless of your level of training, because we're ultimately already exercising direct access regardless of where you are. Even if you have a referral base, most of the referrals are evaluate and treat, right? So you're not really doing a large level of carryover.
But
But direct
master's
access
degree
to the point where you,
nurses
yeah,
practice independently. That's the counter argument, right? We have master's degree nurse practitioners. They're practicing independently without a physician. So why should it be different for us?
yeah,
You
of
know, are
course.
we artificially complicating things just because some of our professionals have a problem with it? And should it be individual scope? And by the way, I felt like as an MPT, I had everything I needed to practice at top of scope. I don't think that transitional doctorate changed the way I practice. It got me a little more comfortable with imaging, but I wouldn't be independently evaluating just from that doctorate, looking at MRIs and saying, I know what the diagnosis is. So just throwing that in there. Are we complicating it just because we're hesitant? Or should it just be, listen, I know my scope and I'm going to take on that risk. If I don't want to, then I can't practice in that setting.
I think the only slight argument there is that physical therapy as a process and as a discipline has a very large and vast practice spectrum. You're seeing cardiovascular, you're seeing neurological, you're seeing orthopedic, and there's potential for endocrine and metastatic processes that you may or may not be able to pick up. So if you're a physician assistant in dermatology, you just have to be really good about being competent in derm, right, or ortho. So I think that we have a very large clinical spectrum of care and processes that we are governing. So we have to be competent, being able to rule out the cardiovascular episode, being able to rule out potential um, oncological problem, potential immunological problem, right? And all of these can present that as a musculoskeletal problem, but ultimately, so Cody, to you, what do you think?
Yeah, I think maybe what your point is getting to a larger picture of like the advanced practice kind of designation might look more like if we were more of a frontline provider, MSK provider, not just direct access, but our patients seeking PT first. So are we their initial contact into the system? So then that, I think that point makes maybe a little more sense from that aspect of maybe you do have an advanced certification at that point. But just as direct access as a whole, I do feel like we are appropriate to be able to screen what is needed, whether it's identifying if it's relevant for PT or not. And then even let's just say you saw a patient who maybe had a process going on that's not MSK related. I would hope that you would be smart enough or maybe aware enough to, even if you set up a plan of care and you weren't seeing change pretty quickly, you would get them referred to the correct provider, so that maybe you initially think it is an MSK process, but actually like, okay, this isn't responding the way I thought it would. Let's get them to the next level of care needed. So I do think there's argument there for maybe both sides, and yours lens for the advanced practice being more from like that very frontline provider, kind of more of that UK model overall.
I think building these thresholds for when you're delivering care, when you're receiving a suboptimal outcomes, do you re-examine it, or do you double down and say that it's just a slow process, right? So then are we good at recognizing that we're not the ideal discipline, or we are not providing the ideal type of care? And part of it is also then the generalist versus a specialist argument, that if you are a general practice physio who is taking over everything, right? You are in a more rural setting, a very large caseload, and you're overseeing neurological, you're overseeing orthopedic problems. You become like a jack of all trades and a master of none, right? You become a little bit less sensitive for these outlier problems. So yeah, it's definitely something for us to visit. But I agree with Dana that we are creating these unnecessary tension points as a profession that they don't need to be there. We can create a national, federal recognition of direct access, federal recognition as a primary care provider, and then we can deal with some of these problems too. If we want to reference the military model again, we have a vast safety profile as a profession. We have over 20 years of encounters in the military as the direct access primary care providers, with a direct safety mapping of clinical encounters, of counteractions. And so we are safe. That's not the question. The question is the steps to get there on a federal level.
I don't want to argue against ourselves, though. So if we would need an additional certification or test or something to practice in a primary care setting, I absolutely don't think we do. And if I'm going to look at like what a nurse practitioner is evaluating, for example, they're working in primary care. There is no reason why we have less of the ability to flag for red flags than they do. I think a lot of this comes down to just personal scope of practice. And if we have that license, then it's up to us to decide, and it's up to our own risk comfort. And if there's therapists that don't feel comfortable with it, they should not practice in either a primary care space for, I would hope at least the vast majority of DPTs that have had all of this education, we would be comfortable in whatever setting we're in. And again, if we're not, then so be it. Then just don't practice in that way. Practice where you don't have that responsibility. But this is a great conversation. I didn't expect it to go down all of these twists and turns.
If I could just circle back real quick, I don't think I answered earlier when you asked about, direct access and should master's level or bachelor's level. I would say that if you're a bachelor's or a master's, you've been practicing long enough, and as long as, like Alex mentioned, if you're not having a 1 year experience, but it's that collective experience, then you're getting better each year, you're growing, you're continuing to learn. And then I know a couple in our clinic that, have been practicing for 25 plus years that I would trust wholeheartedly for my family member to walk in and see them as a first line provider, because they're that experienced and they've just continued to learn. One we had provisional direct access passed last year, and one of those caveats within the bill was that you either had a DPT to be direct access or you had 10 years as a master's, but unfortunately they wouldn't allow bachelors to have direct access. And that was kind of one of those real tension points that if that wouldn't have occurred from the opposition side, then this bill just wasn't getting passed. And so it was interesting to see some of the things where, you had to give a little bit to start to get a foot in the right direction to get that initial bill passed, that hopefully you can go back and then let's revisit this. Let's see if we can change this piece of the legislation. So I think getting to see that, like, you may not win the war necessarily in one go, but hopefully you win the battle and you can just kind of continue on making improvements as you go. But that was unfortunate. Yeah.
It's give and take. You're never going to get
Yeah.
everything you want. And
Yeah.
that's a great lesson. It doesn't matter if it's local, national, it's the same.
So let's move on, guys. Let's go into that AI discussion. I think this is going to be really interesting because I think that your post and both your experience is both riveting and is exemplary to how I really hope that clinicians in the field will emulate what you have done, because it's exactly where we need to be as far as technological adoption and technological application of some of these advanced systems that are available and just under. So tell us a little bit more again about this. And I think definitely tell us how someone who is just practicing right now, how can they emulate your model to build these clinical decision tools to help their practice?
Yeah. So, like I touched on last time in the previous episode, I mentioned kind of how I was starting to use AI in the clinic and what that looked like for me. And I think I initially talked about that patient I had who has like a higher level ACL functioning patient. First time I had that particular diagnosis, case, patient population. So I needed a little more assistance on, synthesizing research and evidence. And I've just continued to dive deeper into using AI, clinically and how can I implement it. I think I started out like most people using it kind of like a search bar, almost like a replacement for Google. And then just as I used it more, realized, oh, there's a lot more I can do here as I learn more about the features and different things. But I think one of, a big topic I see a lot is documentation and AI scribes and all of that, which I think is great and will probably be super beneficial. If I could have the ability to just have it kind of record my session with a patient and outline a note for me and kind of help that aspect would be helpful from a documentation standpoint. But going deeper, I think using it for clinical decision support tool and not replacing my thought, not replacing my decision, but helping me make a better decision. And so the way I've begun to use it is I use Claude mainly. I like to use the projects feature. So I talked about last time the ACL patient. I uploaded several articles, probably 20 plus, whatever the context window could handle, and then be able to ask it questions about my patient's progress with different objective data and what he's telling me from a subjective standpoint about pain or different aspects there. So I think you can really begin to just play around with what is that area you're interested in, or do you have a challenging case? You normally might go and research and read a bunch of articles, which I would still say go do, read the articles, understand them, but then being able to apply them and put them together, that's where I feel like AI is really helpful to be able to query that information, ask questions, synthesize it, bring it all together, and really just allow you to make even better decisions, especially for an early grad or early career. Rather, it's been super helpful from that aspect, just to give me a little more confidence in like, okay, the decision I'm making is helpful and here's why, here's the evidence, or I can challenge, this is my thought process, tell me where I might be wrong based on this evidence or based on what or that sort of thing.
I think it's really interesting that both the use of Claude and the use of large language models to help diversify, right, the viewpoint of the individual's recovery journey. If we want to talk about that scribe feature a little bit more, having consulted for an EMR provider with an entire portfolio of these advanced AI products and processes, the scribe feature is by far the most popular and the most utilized. We as a profession have adopted scribe so much more than any other AI-driven processes. And how do you think we can build on it beyond just being a time saver?
Yeah, I think so. It's not something we're currently using, unfortunately, with the health system. It takes some time to implement some things and then implement it across the whole system. But I'm hoping that we'll get that implemented at some point. I think that's probably the easiest entry point to show value, and like a pain point for a clinician is like you have this documentation burden. Maybe you're in a higher volume clinic or whatever the case is. It's going to help you reduce notes at home or whenever you have to write them. So really helping with that mental load, the energy level, and I think that's just an easy entry point. I think as far as a clinical decision tool, I would love to see it built into our EMR, our system, where it can pull together, all the notes this patient had from primary care, from cardiology. It can give me a synthesis of what do all those notes say, rather than me having to read each individual one, which I do currently, is go back and look. As long as they're in our system, I can see those things, but kind of give you a synthesis. Here's a breakdown. Here's the comorbidities. Here's what you need to be aware of, and then help kind of stratify, like you've talked about, whether it's back pain or whatever the case is, some things you may want to be thinking about that could be playing a part in this clinical picture. And then within that, as I'm getting a subjective, let's say I'm using an AI scribe now and we've gone deeper down the rabbit hole, then we're getting the subjective and then the AI is listening. It's integrating in from what we see from a clinical picture standpoint, what I'm seeing. And then I think that would just help make better decisions overall. Obviously, you still have to have the human element of connecting with the patient. And I think that's the hard part. Oftentimes we call them soft skills, but really they're hard skills of connecting. And then you just being able to synthesize what the AI is telling you, use that information, and then implement that in a way that's building therapeutic alliance, how we normally would with a patient.
Yeah, I think if you guys remember the Sufi tale where the five blind men touching an elephant and each one giving their version, like, is it a tree? Is it a snake? Because I think that's what the AI and that's what these models do, is they combine all of these complexities, all of these layered complexities, and gives you the highest probability, right? It's a guess engine and it's a probability engine. So, do you think, Cody, there is a need for more of a standardization of how we even collect clinical data? So, not even talking about EMR, but more from the process perspective, because I think that the biggest lost opportunity is patient data collection from the standpoint of economics and from the standpoint of resource allocation. We have this aggregate of complex patient-related data that, unlike you, who is using it on a high level, most clinicians, they just have their SOAP notes that they're generating on a daily basis that serve no function beyond the fact to satisfy the bare minimum need to be eligible for reimbursement, right? But if you think about it, the process, the point is that you are collecting this patient-specific data that can be applied both on a large scale, on a macro scale, and on a micro scale towards a better understanding of this clinical processes.
Yeah, I think, are we thinking specifically like functional outcomes data, or what specifically from that
Outcome
kind of
data,
standpoint?
EMR data, like even your notes, when you're creating a daily note, right? Your daily note, most of us create a daily note to satisfy billing purposes, right? But there's so much more that can be done with this patient-specific data. Like you have subjective data, you have clinical observation. All of these points are actually pertinent to better understanding of this clinical process and clinical trajectory, because it is a continuum. So this note can field your better understanding of, do I do A, B, or C the next time I encounter this patient? Because you are seeing these individuals for the episode of care. So these notes are a missed opportunity to refine these episodes of care into a higher level of standardization, as well as a higher level of qualitative care delivery. If I knew what I did the last 4 times and the system guided me that based on this, the probability of you doing A is better than B towards an optimal versus suboptimal outcome, that's how we can use this clinical data. And what we're doing now is we're just using that as a reference point potentially at best, and at worst we're using it as a way of satisfying a commercial payer's needs to be eligible for reimbursement. Right?
Yeah, I
I'm
gotcha.
just going to interject to say this, we're talking again as the microcosm of the episode of PT, where this information and the output and the outcome of the episode and all of the communication with the patient, what we collect, has value in refining and getting a better outcome for our patient. This is the kind of thing that's done in population health management and ACOs. They need the inputs from every component of the continuum of care. This information is not that if should we do it or, is it the right thing? We have to do it. They're already doing this in, advanced primary care, in ACO health management. They're taking inputs from all across the continuum. They're putting them together, and then they're presenting them in the more advanced applications. They're presenting them to the nurse care manager so that when they call the patient to discuss their care, to engage them in, let's say, complex care management, we need for our notes to be consolidated into something that can then be sent over and connected to the rest of that continuum that the nurse care manager is using. And right now, I don't know of any therapy EMR that's connecting into a pop health management tool. These pop health tools are taking inputs and bringing them together. So besides the fact that we should be doing it for our own care, this information has other uses. So we have to figure out, how do we get this to others so we can start to show we're part of the patient's care journey and the continuum and part of what needs to be managed across for pop health management.
That's a perfect interjection, actually, Dana. And I think that it has been done, and it's actually been well studied on a local level. If you look into that data repository from ATI, so ATI since 2016 has been really doing a terrific job collecting outcome data, collecting experience data, and collecting clinical economic data, right? So just the episode of care and the utilization data. And so those three factors, the experience, the outcomes, and the utilization, are helping them identify the optimal and suboptimal encounters within their workforce, so that a clinician that has optimal encounter based on specific region or specific diagnosis versus suboptimal encounter compared to the larger baseline. Or so it's there's actually really cool studies on this, but we have not done this on a global scale, right? On the industry-wide scale. And I'm not really sure that ATI has done this for a self-promotion purpose, or has done this to justify higher level of reimbursement, or to have this seat in the game, right, with the payers. So Cody, what have you seen on this?
Yeah, I think it definitely has to be standardized, just getting back to that for a second, because if you don't have a standard, if you don't have a process, then you can't continue to improve it. So I think sometimes standardized sounds like a bad word, but really it's a good thing. You have to have standard work to be able to have a process improvement in place. I think in general, yes, we need, the functional outcomes data. So how are we collecting that on a granular level in the clinic, whether that's your ODI, NDI, functional stuff like that, but then getting to a larger picture of, like y'all talked about, how are we then tracking, is the episode, or when I see this patient, or when we see X amount of patients who have low back pain, how many are then having to have surgery, or how many are we preventing? How are we preventing ED visits and all those things, to really be able to show our value and get back to kind of the value-based care conversation we've had before. And recently I met with, I think I might have talked about it last time, I met with our ACO director for our health system, who is actually a PTA. So it's cool that he's in that position, and he was our clinic manager as well. So it was neat to be able to, make that connection and get to talk to him. But really, like you said, Dana, getting to see all the information they have from a population health standpoint of what they're looking at, what they're tracking. Something we plan to look a little deeper, and what we're working on now is, how can we get our PT clinic more integrated into the ACO? How can we start to show them our value with the patients that their ACO is responsible for? And then looking at a granular level of, okay, what is the spend to look like if they go to this clinic, if they go to our clinic, if they go to whoever it is, getting to see, are you actually better? Are you doing a better job than the clinic down the street or not? Because I think if you can't benchmark yourself from that perspective, if you don't know where you're at, then you don't really know where you need to go. Standardize data collection, implement a process to improvement. I think if we could do that as a profession, or as individual clinics, and then larger, it would be a beneficial thing to be able to see the impact we truly have and be able to demonstrate that.
You can actually see the examples of this, Cody, that can be emulated on a local level from data registries that have been created around the world. So you can create just your own clinic data registry, where you aggregate all of these outcome measures into a larger bucket, essentially. And then you can still use a language model to process this data. So just the analytics can be outsourced to the machine, and then you can start to see trends. And then picking up these trends is how I think you both provide this data to your partners, but also use this data to refine the process. And then I think the key here also is that we as a system need to do better is building feedback loops. So we collect, we analyze, we operationalize, and then we start that all over again. So it's the continuous cycle that we get stuck on one process. So we just get really good at collection, but then no one is analyzing it. Or we become hyper analytical, but then nobody's putting it back into the operation, into the refining process. It's that feedback loop system that needs to exist on a local level, just in the clinic, because we need to have these monthly meetings that we talk about outcomes. We need to look into the development process. That look, we have 10 clinicians. Some are better at one diagnosis, some are better than the other diagnosis, and not just subjectively that I feel like I'm really good at taking care of back pain, right? But objectively, my outcomes are superior to your outcomes, or inferior based on outcome measures, based on utilization measures. And that's the discussion we have, and that creates a viable feedback loop that improves the process, so that within a year, you can actually say that our clinic is doing a significantly better job than a neighboring clinic, because these are our outcomes. This is our data. Where's your data, right? Show us the receipts. So
Right.
that's
One of the things that this Center for Medicare and Medicaid Services I was looking at is EMR data to determine the risk of a population. So if you think about a commercial payer, right, they have a set pot of dollars, and those dollars vary depending on the risk level of the population, just really broadly. We've got all this data from EMRs, and we have the ability to do bulk fire, which essentially just means APIs, and there are already data companies doing this. Don't we want the data for the physical therapy practice to factor into how payers determine the spend that they would expect in a population? So just, I guess, food for thought. We can't sit on the sidelines, in my opinion, and not be demonstrating that not only are we willing, but interested and able to provide our data, and that there's real value behind both the risk that we identify in function and safety and pain and all of those things that we do. And it should be part of the risk profile of each individual person. Just wonder what your guys' thoughts are on that.
so you look into that EMR data, and I've seen this used both in the economic sense and also in the policy sense. And unfortunately, EMR data that we're extracting is, for the lack of, to keep this show PG, it's poop. But it's an unfortunate sense that poop in, poop out, right? And we have the way you aggregate this EMR based data is that you have a data lake, a data pool, right? And then you start to cleanse it based on the factors that allow you to have a much more pure extraction of this patient-specific data. But patient-specific data in physical therapy sense is absolutely nominal, because we are not discriminant in how we utilize ICD, partially because of how we've been shaped. Our ICD-10 codes tend to be generic, so we don't have a very pure analysis of these diagnoses and how the outcome measures based on diagnoses, and the clinical care data, so the utilization data, because we have limited use of the CPT codes. The billing also becomes much more nominal and non-objective. So we have 4 dominant CPT codes. We have maybe 5 or 6 dominant ICD-10 codes that we use, and everything else is irrelevant. So even if we become much more stringent about collecting these data registries, it still becomes a poopy data registry, because it's impure. It does not have any significant impact on, I think, policies on a macro level, because we can make decisions, but these are not factor-based decisions based on this. So what do you think?
Yeah, that's interesting to hear, Dana, kind of what you talked about there, and the complexity and the risk stratification. I am surprised that functional status isn't included, and it seems like it definitely should be, especially when you consider if we're thinking about fall risk or those sorts of things.
And so I bring this up in this setting because I hope that some therapists start paying maybe a little bit more attention to this. So much of the risk of a population depends on their function, their safety, their pain levels, and how that contributes to their overall holistic picture. It's a good time to be thinking about having a bigger awareness of what's happening. All of these things trickle down to impact us. And then once they do, we say, wait a second, this isn't fair. But we weren't part of the conversation to begin with, because we're more in our own therapist vacuum. And there's value in being a part of the other conversations that other providers and payers are having, so that we can ideate with them and contribute what we know to be a really important component of patient risk.
Yeah, I mean, just thinking about, if you're not including functional status, then you're missing such a huge piece of the puzzle. If their functional status doesn't allow them to be physically active, that's only going to be detrimental and going to continue to have a decline in function, and then it's going to negatively impact all the other diagnoses they may have or issues they're dealing with. And then just thinking a larger picture, like fall risk of how many times in the hospital I've seen an older adult who has fallen and had a hip fracture. And then if that's not included in risk stratification and you're missing out on classifying, what that cost would be, and you're not considering this person have a fall risk and the likelihood of them having a fall and then having a hip fracture, if they have an accompanying, sarcopenia, osteoporosis, osteopenia, all of those things.
So this is a great time to pay attention, starting with the beginning of this administration, this new leadership at the Center for Medicare, this as an opportunity, pay attention to what's being said and think about what the implications could be and whether or not we have a voice and whether or not we should, right?
SAFE Act has been
Yeah.
prominently featured on APTA and all the efforts. And what we're trying to do is we're just trying to get coverage for preventative care that will get reimbursed at $130 once a year by us and our professionals. So it's a one step in the right direction. Yeah, this is a perfect cue, Dana, to pay attention to government policies, to actually be an educated consumer and an educated provider, to understand where things are coming from. So lastly, guys, let's discuss the inclusion and the exclusion of professionals in our APTA efforts. And so the discussion is, should APTA be focused on only providing resources and providing support to clinicians providing actual factual clinical care, or should we widen the net of inclusion to include all of the clinicians and all of the administrators in a musculoskeletal setting that have left the clinical work but continue to govern, continue to standardize policy like yourself, and continue to actually impact musculoskeletal care provision, even if not directly, while being in physical therapy clinics setting and services?
I'd love to hear what your thoughts are on that, Cody.
Yeah, I mean, I think the APTA as a whole should be supporting all PTs, whether you're a treating clinician, whether you're in a non-clinical role, whether that's just academic, maybe you're a professor, whatever the case is. Physical therapy as a profession, it's not just treating patients. It takes a lot more than that to create the profession. I think looking at other healthcare providers, so physician groups or nurse practitioners, they're going to be in a lot more different diverse roles as well than just treating. I think within ours, it should be both. So I think we need folks like both of you who are not necessarily in a treating role every single day, but you're doing really important work in the roles that you're doing, and you're learning a lot from a non-clinical standpoint and the different industries that you're in, and how useful that information is and how important it is for our profession. And then for me, especially as early career, I've learned so much from both of you and Dana, a better understanding of how that process works, what that looks like, what a voice for PT could look like, why it's important for me to understand it. It's really been eye-opening. So I think overall it should be both.
We're in a vacuum, and this is not helping. We should be part of the larger healthcare delivery community, but voices by folks who are doing other work contribute to depth of understanding and bring different perspectives that can only benefit the profession.
Yeah, I think it's that old forest and the tree argument, right? Is like, when you're in the forest, don't forget to look at the trees. I think it's been very much a focus on the clinical care provision and empowering clinicians in the field to optimize their care delivery. But there has been probably an oversight of all of these professionals that may not be providing clinical care directly, but are contributing to the well-being of the industry. But the resources are not infinite, so the finite resources had to be allocated. And I think the bucket that they were being put into was disproportionately that clinical bucket versus the non-clinical. There's a bigger world out there, and there's much higher level of complexity that needs to be recognized and supported. There is a significant now contingent within APTA that is trying to move the policy towards this innovative new approach of supporting the non-clinical roles, supporting the innovation, but also supporting the roadmap for the profession to move and evolve forward. There's going to be a really good summit in APTA in July, that Future Rehab Summit, which historically has been more about innovation and clinical innovation, and now is being morphed into more of a clinical recovery and clinical process that Cody is doing, right? Like using large language models, and how do we use technology to actually refine and help clinical cause. I think once there, this will be a very good way to also add some of the variables that we're discussing here, which are policy driven, the macro level driven policies. So to make the long answer short is, we can do better, Dana and Cody.
Any last thoughts or anything else you want to share, Cody, as your session 2 with us wraps up? And thank you again for being with us. So it's just awesome to hear the fresh perspective of a young, very motivated therapist. It's those who take the time, even though they're not, necessarily being paid for that extra time or effort. Those who take that extra time to learn other things are the ones that have opportunities open up for them and have more choice in their career direction, and I think more satisfaction and control.
Thank y'all again for having me. I always like talking to y'all and listening, and it's always energizing for sure. My goal is to create value for the listeners or whoever I'm interacting with. Something Alex mentioned when I was talking about AI originally, decided to create a course. I'm just calling it AI for PTs. So I'm trying to make it super actionable, 90 minutes or less, really short lessons, maybe 4 to 8 minutes, that I'm hoping to have launched by June 1st, and how you can implement it to really just create value for yourself and your daily career and life, and for your patients as well. Would love for people to check it out and tell me what they think about it. Open to all feedback, and again, interacting with any listener or anybody that wants to connect with me on LinkedIn or elsewhere. I'll put my email in the description as well for y'all.
I really would want to plug that. I think anyone and everyone listening should really give Cody's classes a try. I think there's no wait for us to evolve as professionals. You have to be. The only thing that's better than a machine is a human using that machine. And that's like Cody's, your class will definitely instruct clinicians and entrepreneurs to use this machine constructively. So awesome. That's really good.
Don't be afraid of it, folks. Just,
That's right.
Because others are going to learn. So be one of the first that really learns to use this in various ways.
Awesome.
All right. Thanks, everybody. Episode 11 is a wrap. Thanks again, Cody, for being with us.
Dana, Cody, this has been great.
Thank y'all.
Thanks for tuning in to another episode of Future Proof PT. Before we wrap up, let's highlight key takeaways from today's fascinating discussion with Cody. First, the importance of functional status in healthcare risk assessment. We learned how critical it is for physical therapists to advocate for including functional measurements in patient risk stratification, as this directly impacts patient care and outcomes and quality of care. The second is staying engaged with healthcare policy is important. As physical therapy professionals, we need to be active participants in broader healthcare conversations beyond just physical therapy, especially during times of administrative change at organizations like the highly influential Center for Medicare and Medicaid Services. Third, embracing diverse roles in physical therapy. The profession benefits from supporting both clinical and non-clinical PT professionals, as different perspectives and experience strengthen our field as a whole. And we see this already by other healthcare professionals who understand the importance of this, and we can learn from them. And fourth, leveraging AI in clinical practice. Physical therapists can enhance their evidence-based practice by using AI tools to stay current with research, streamline documentation, develop more personalized treatment plans, all while maintaining the human touch essential to quality patient care. Remember to also check out Cody's upcoming AI for PT course, launching June 1st, and don't forget to connect with him on LinkedIn for more insights on incorporating tech into your practice. Join us next time as we continue exploring the evolving landscape of physical therapy. Don't forget, please, to subscribe and leave a review if you enjoyed the episode. And again, thanks for tuning in.